Hello, my name's Jennifer. I'm the current fellow at the MARTA ICU, and I'm going to be talking about central venous access today. So the outline of this presentation, so we'll talk about the indications for central access, as well as the different types of lines and when you might choose one line over another, the anatomy, and likewise choosing your site selection, any contraindications, and just a little bit at the end about safety and quality. So the indications for a central line or central venous access of any type are fairly broad, but do fit under fairly standard headings. So drug administration, and really, particularly in the ICU, multiple drugs requiring multiple lumens would probably be one of the most common indications for a central line, as well as the irritant drugs, which would cause significant morbidity in any peripheral line insertion and running. The other indication would be for more subacute indications such as long-term, so for example, hospital in the home IV antibiotic use or total parenteral nutrition. Monitoring, and monitoring is really something that we use very commonly with our central line access. So pressure monitoring, temperature monitoring, particularly for pulmonary artery catheters, mixed venous and central venous oxygen saturations, as well as the application of advanced hemodynamics, which would include thermodilution techniques. Sampling, so blood sampling, which really do fit into the fifth indication there in terms of difficult access. And then therapeutic indications such as ECMO or renal replacement therapy. This presentation really will focus on intensive care applications of central venous lines. I know that a lot of the cohort listening might be emergency or anaesthetic background, but I'll be sort of having a little bit of an ICU and critical care swing to it. But obviously on the day, we're happy to take questions and have a chat about other indications. So in terms of the lines, what I won't be talking about is any tunneled lines, which are usually not relevant for the critical care applications, or completely indwelling lines such as portacaths. But otherwise, the lines that we do place and we do use regularly in ICU would be your standard central lines, peripherally inserted central catheters, VATS caths for renal replacement therapy. Your pulmonary artery catheters are less widely used currently, but are still indicated in particular patient groups such as severely shocked patients with mixed shock state, or post-operatively in some patients such as cardiac surgery. And then of course ECMO catheters, which can be both venous and arterial. I put this in here really just to make the point about the sequence of events inserting a central line, and just taking time, particularly for those of you who are just starting out putting in lines, to have a very conscious thought about your setup, what you need running through in order with your equipment before you start, and just really sticking to that same setup the entire way through, whether you've done 5 central lines or 5,000 central lines, because it's this way to be able to minimize any risk to yourself, any risk that you've forgotten any equipment, and really just to train your muscle memory for those 2 a.m. central lines where you might not be at your most cognitive robust. This is an ultrasound course, and so a lot of this talk will also be the ultrasound applications of safely inserting and maintaining central lines. So the long and the short of it is that ultrasound is now the gold standard in terms of placing central lines, and that ultrasound can be used both as a dynamic or an indirect application. And I'll go into what I mean by those two things in a little bit. So what does ultrasound actually contribute in placing a line? So there's some obvious stuff. So obviously you can see beneath the surface. But specifically, you're able to see the deep structures. And for patients, what I'd like to sort of bring up in this discussion today would be clinical situation of the patient is actually really key to when putting a line in, knowing your patient, knowing what the risk factors that are specific for that patient, as well as the general risk factors. So, for example, visualization of the deep structures would be very important in someone with severe COPD who's trying to put a central line into the subclavian vein, and you categorically would like to miss the pleura. A lot of this is quite obvious, but it's important to have a think about because it does help with your decision-making processes, which we'll talk about a little bit in a minute. Obviously, negotiating the needle path. I've put, for example, with respect to the artery, but obviously also with respect to other deep structures. And negotiating the needle path for people who are just starting out with central line insertion is the hardest part of the entire thing. So your ability to be able to visualize your needle tip, to be able to follow that, to be able to see it inserting into the correct vessel is something that, particularly in my juniors that I teach, is something that we take a lot of time to try and get established, because once that's established, really the rest becomes fairly straightforward. Confirms that the anatomy is in the region that you're attempting to put your line in is normal. And again, each particular person is different, and some people will have abnormalities of their anatomy, and so worthwhile having a look with an ultrasound. And I would encourage you to have a look if time is not particularly crucial. Have a look with an ultrasound at different regions to be able to see the anatomy and which particular site you'd like to go in first. Obviously, check that the vessel is patent. We'll talk about that more in contraindications. I've already said about the needle into the correct vessel, but I guess more importantly, a second check that the guide wire is in the correct vessel, that it stays in the correct vessel, and then it's definitely not in the wrong vessel prior to dilation. And last but certainly not least would be that ultrasound use is now definitely a standard of care. It's endorsed by all of the critical care colleges as the gold standard, as well as professional bodies such as ANZICS, and as well as governmental health departments in terms of minimising risk factors to patients whilst in hospital. So this is not just something that has become just because there's more ultrasounds around. It's actually quite evidence-based. And so supraclavicular lines have the most evidence around them, and out of those it would be the internal jugular vein. This is a Cochrane review about internal jugular vein in central line insertions, and it really is looking at the traditional landmark insertion versus the ultrasound guided. Now they do separate into direct and indirect. What do you mean by direct? I mentioned that earlier, and I use the word dynamic because I think it's a bit more obvious, and that means you are inserting the central line under ultrasound guidance throughout the entire process, as opposed to indirect, where you use your ultrasound to identify your anatomy, to pick your insertion point, and then you put that down whilst you do the procedure. Hopefully this projects well, but this is probably the key forest plot of the entire Cochrane reviews. This Cochrane review was from 2015, and it used 35 trials of landmark versus ultrasound guided IJ central line insertions, so that was just above 5,000 participants. You can see at the top the most evidence is with direct use, and clearly there's a significant outcome in terms of the pooled estimate of outcomes favouring ultrasound guidance. That is also applicable to the second group, although there's less studies, and this is the indirect puncture, or where you just identify the structures and then put your ultrasound down. And the third group is less statistically significant in that the pooled estimates cross the marker of nil effect, but you definitely still see a trend, and that's where really the studies didn't identify whether they're using direct or indirect puncture, but were still clearly comparing ultrasound versus landmark approach. So what were they looking at? So they were looking at a number of different outcomes, of which they were all statistically significant, and they included the rate of successful catheter placement, the successful first attempt placement, so for ultrasound guided it was 57%, and the reduced time needed for successful cannulation, all of which were significantly improved with ultrasound use. The overall incidence of complications was reduced by 71%, and specifically also the incidence of inadvertent arterial puncture. So this Cochrane review really has fueled what I mentioned on the previous slide about the policy changes, and hence why there's really no reason why someone would be inserting a central line without an ultrasound, particularly now the ultrasounds are quite freely accessible. The infraclavicular access, so lines below the clavicle obviously, have less robust evidence to guide ultrasound use in them. Although the trend is definitely, the evidence is there that it improves success rates and decreases risk of puncture-related complications. Okay, so then what do we actually look for pragmatically on the ultrasound? So the first thing you'd probably do is want to identify what your vein, which vessel is your vein and which is your artery. So I do have a few members of the audience here. So just shout out anybody. Really, what are the things that you look for when you're trying to identify a vein versus an artery on ultrasound?
If they're compressible.
Compressible, so would you expect the vein to be compressible?
Yes.
Yeah. Anything else?
Pulsatility.
Pulsatility. Yep.
Thickness of the wall.
Wall thickness, thank you.
The shape of the vessel, so arteries tend to be much more circular.
Yep, as opposed to potentially oval or elongated. Yes, of course. You can see the rest of here, and really it's about building evidence to convince yourself using the different things that you know about anatomy to be able to determine which is the artery and which is the vein. There are some, particularly in the ICU population, I would, in terms of pulsatility, then I've certainly seen people who are particularly shocked, whose arteries are not particularly pulsatile, and calcified vessels can become quite thick-walled, and calcified veins can mislead you. However, what the theme is here is not one particular characteristic that we would be reliant on, and it's, as I say, it's about knowing what is normal and then identifying to convince yourself that you're entering the right vessel. What I'd like to talk to you about is actually about a bit more ultrasound specific rather than just anatomical, which is what my team have answered here today, and it's about using Doppler on your ultrasound to build, again, more evidence towards identification. And it does fit in terms, so this here is a Doppler flow. There's a vein and there's an artery. And you've got a gate, so this is a pulse wave Doppler flow, and you've got a gate that's sitting in the vessel that's the inferior of the two there. And you've got an arterial waveform that you can see as a result of that. And as was mentioned just in the answers about pulsatility, and this is able to, not only are you able to see the pulsatility in the sense that the flow is coming in regular pulses, but you're also able to identify a clearly arterial waveform, which is the flow through that gate in this pulse wave Doppler. The other thing you can see is that there's a mix of colours in what we now know or are starting to build evidence is the artery here. Now this is called aliasing, and it's where the speed of the flow of the blood in this case is too fast to the settings of your ultrasound. And although it's seen as a bit of an artifact, it's also very helpful in the sense that it adds the fact that the flow in this vessel is a lot faster than the flow in the vessel above it, which would be the corresponding vein. Similarly, in this image, you can see two vessels. You've got the top and the bottom. The pulse wave here is through the top vessel. Now, you'll note that there's a pulse wave underneath, and there's sort of a few little spikes, but not a convincing arterial waveform. And then the same vessel below, there's a much more reduced signal in terms of your pulse wave. And what this is actually a peripheral vein where the top indicates some reflected arterial wave from the artery below, and then a tourniquet is applied to the arm in which these vessels are in, and you lose that reverberation. You'll note that the actual colour of the Doppler is the same, which is a little confusing sometimes in terms of identifying, well, shouldn't I have the opposite direction if I have a vein and an artery? Really, I'll put it to you that at the different parts of your cardiac cycle, particularly with your arterial pulse, you'll have a change in direction either to or away from your ultrasound probe. And you can see that most clearly in the bottom one here, where you've got your arterial wave, which is moving in time through that area. So it depends on which part of your cardiac cycle you're in as to whether the blood flow is to or away from your probe. So don't get disheartened. Use your other ways of distinguishing, and we'll practice this in the workshops. So technique. So I'm sure there'll be a variety of experience in the room. Some people have probably done several hundreds of these, right down to some people who have seen a few and done none. So we will just go through the technique, and I just wanted to point out a few things along the way specific to the ultrasound setup. So before we start anything, I would always encourage you to know your clinical situation. So if you are the person putting in the central line, know the indication, know the background of the patient, and know the reason and any contraindications. And this is important because it will mean that you're making the right decision in terms of your placement, and you're avoiding any specific complications for that patient, which I've mentioned earlier, and we'll go through a little bit more in a minute. Consent if able. So consent of the patient if they're able to give it, or of a substitute decision maker, and then positioning and setting up the patient. I would argue that positioning and setting up is something that, if done well, can save you an enormous amount of time in actually completing the line. A lot of the time, the putting the line in is the thing that takes the least amount of time. In a resuscitation where there are upwards of 6, 7 people in any one bed space, there will be a certain amount of competition over land, and so you and your ultrasound are taking up a particular portion of that. So being able to be self-sufficient, to set up your ultrasound, to set up the patient and be able to get out of there as quickly as possible is something that will become necessary along the way of your training. The other thing, if you've got time, and I mentioned it before, is just have a quick, even a couple of seconds, just a bit of a scan of the area in which you're planning on placing your line, to make sure that there is actually a vein there, it is actually patent, and it is indeed the place that you want to start. The rest is very much the same for every single time you put a line in, so full sterile technique, and there's no questions about that. If their sterile field is broken at any time, which of course it is sometimes in a critically unwell patient where there's other resuscitation ongoing, you must start again. They'll just go through this. So here we've got a central line. There's chlorhexane alcohol being used to prep the site, and then a full body drape to ensure your field remains sterile. Setting up your ultrasound probe. So the ultrasound probe is one thing that sometimes doesn't come in your central line kits. It will depend on what unit you're in, is the sterile cover for that. I would advise you to practice a way to be relatively self-sufficient with setting up your equipment, and this is a particular one where having a way of getting your sterile field on with your ultrasound gel on independently will make you a lot more useful to have around, as opposed to needing to wait for somebody to hand you the probe, and we can go through that in the workshop a little. You've already, as I've hopefully mentioned, and you've hopefully attained, set up your ultrasound machine in a position, and your patient in a position which helps with you being safe in terms of not having to look around over your shoulder, which is never sustainable for yourself and certainly will increase the amount of errors that you make, and also somewhere that's out of the way of most of the rest of the staff in the unit. Identifying your vein, and clearly they've got a nice looking vessel there. Infiltrating of local anaesthetic, and I would encourage you to use this as your trial run in terms of identifying your needle. If you can see your needle using ultrasound and you're infiltrating your local anaesthetic just above your vein and along the tract in which you're going to dilate, then you should be fairly confident that that's the same tract that you will use, and that you'll be able to identify your needle for the actual central line. The Saldanger technique is something we use for almost all of our line insertions. For those of you not familiar, it's basically introducing your needle into the vessel, then placing a guide wire through your needle, making sure that your wire is in the right position, and then dilating over your wire, and then placing your line again over your wire and removing your wire after that. Don't worry, I'll go through that a little bit slowly for those of you that need it in the workshop. I just wanted to make a point here about the position of the way you're holding your ultrasound probe in relation to your needle. Particularly in small humans or in really, really big humans with lots of subcutaneous tissue, it matters about the angle of your ultrasound. You can see just here on the right, you've got your trajectory of your needle. And depending on even just a small 10 to 15 degree tilt in your ultrasound, you can cut through the trajectory of your needle at different points. What I would encourage you to do is to be very dogmatic at the beginning, and if you're obviously an expert at this, to just keep focusing on making sure you keep your ultrasound probe perpendicular to the skin, so that you are always seeing the needle tip and not the shaft of the needle, and that will avoid quite a lot of inadvertent arterial punctures and other anatomical punctures. Inserting the wire. So the wire should feed very easily through. So once you're into the vessel, you'll have a nice venous colour, nice non-pulsatile flow. And you'll be able to insert your wire very easily without any resistance. Holding your wire and never losing it down into the vein is one of the key points to learning, and it requires a bit of thought initially at the beginning. Having a sterile technique and never losing a wire are one of the two important things about putting a line in. However, the wire is something that's super helpful in terms of identifying that you've got the right vessel prior to dilating. So one of the tips I'd like to say is that identifying your wire in two planes is better than one, and identifying your wire in two planes in the vein and empty in the artery is better than anything else. So what I mean by that here, you've got a short axis vein where you can see your wire, and then a longitudinal axis where you can see the wire taking quite a nice trajectory and obviously not going to hit and go through the back of the vein. And then I'd like to actually encourage you to do a third view here, which is to do a longitudinal view of your artery and show that your wire is actually not in there at any point. I've certainly seen it done where we've got a nice venous puncture, but unfortunately the wire's transected right through the vein and gone into the artery, and so all of your usual tests for seeing that you're in the vein were positive. There was a blood gas which showed a venous blood, and you could see the wire in the vein, but what wasn't seen, that it was actually also in the artery. In terms of dilating, again, it's very something that will take a little bit of practice, tensioning the skin so that you're not tenting as you place the dilator in, and of course letting the guide wire guide you. So not bending your guide wire so that you dilate in the way that you want to because it's awkward for you, but the guide wire is there to do exactly that, is to guide the direction. And so let that happen. If you bend the wire across and then try to dilate, you'll end up bending the wire completely, which is tricky to get out of. Placing the catheter over the guide wire, making sure that there's a piece at the end that comes out and you hold before you lose the proximal part of the wire. And then this demonstrates just ensuring that you've got your patient, that the free lumen is covered once the wire is removed to avoid embolism. Flushing and aspirating, making sure that all of the lumens are patent. Securing in all four positions, so that includes the two butterfly wings at the proximal end and at the distal end, and also the two on the box clamp at the proximal end. Then dressing with an impermeable dressing. Now, site selection. So why would you choose to do one particular site over the other? Now, these are not definitive rules, but they're considerations. And a lot of it boils back to what I've been harping on throughout most of this presentation, which is knowing your patient and knowing the clinical indications. So things that will influence your decision will be supermorbid obesity of a patient, which will make quite often the femorals quite difficult, and even potentially the internal jugulars. Bleeding complications, so bleeding diatheses. Now, I've got a few numbers there. Again, these are rough rule of thumbs instead of standards by which everyone applies. Obviously, you would consider whether or not the patient needs to be transfused for safety, or whether somebody with quite a lot of experience of putting lines in might be the preferred operator in a patient with these type of risk factors. Similarly, positioning. So someone who you don't want to put head down. So for example, a traumatic brain injury or someone who you're trying to control the ICP in, you certainly don't want to put them head down for 30 minutes while you put a central line in their neck. Similarly, the same type of person in terms of obstructing venous drainage. Tolerance of complications. So that would be your pneumothorax in your hypoxic patient, your person with a difficult airway who, if you get a neck hematoma, could be difficult to intubate in an emergency situation. Similarly, hypotension, having a think about what your vessel's going to look like in terms of collapsibility and whether or not you need to give the patient a little bit of fill or a bit of optimization prior to starting. At the actual site, if there's an obvious reason not to go there, then obviously that makes sense. So the tricky patients with this would be severe burns who have a high body surface area. Quite often burn surgeons will be able to graft an area for you, but sometimes that can be difficult as well. Previous central line insertions, although it's not a absolute contraindication, you might try to avoid those lines, particularly if there's potential for a thrombosis in that area. Infection on the site, now that probably is one of the closest to absolute contraindications that we get. And I've written there presence of a left bundle branch block, but that's probably, it's only relevant really in a PA catheter where you might insert a right bundle branch block by placing it. There's pros and cons to every line, and there is some evidence about infection risks. There's been some so it's not meta-analysis level. There are some randomized control trials which suggest that maybe there's lower risk of infection in the subclavian lines as opposed to the internal jugular or the femoral. But that is not the only factor in terms of deciding which site to go. I won't read through these because I think it's something that you'll be able to refer to in your own time, and it does actually just repeat a lot what we've already described. Making a site selection, I think, is actually something that's underappreciated, particularly in people who are just starting out in ICU. A poor site selection can actually mean that the patient's exposed to a second procedure and the complications that come with that. So please do talk to your seniors about making that decision early, and it also gives you an idea about what the decision-making process they use is, and be able to sort of mould your own decision-making processes around that too. Right, so the different lines, we'll go through a bit of the anatomy, and that's because it's important to know the anatomy when you're looking with an ultrasound, so you know what it is that you're actually seeing. So the subclavian vein, and this is one of the most simplistic images that I could find, but that was on purpose. So in terms of the anatomy, superior, so the subclavian vein obviously becomes the auxiliary vein. I'll talk to you about why I like the auxiliary vein in a minute. But in terms of the surrounding anatomy, so superior to the subclavian vein, you have the midpoint of your clavicle. And this is important, particularly when people were using landmark techniques. And I must say, in terms of the subclavian vein, although I would argue you can actually do it ultrasound guided, it's probably the last remaining line where the landmark technique is still used fairly commonly. So superior is the midpoint of the clavicle, anterior would obviously be the skin and sometimes the external jugular vein, and the subclavian vein does pass behind the clavicle as well, more medially. Medial will be the trachea as well as the rest of the great vessels, and then posteriorly you've got your subclavian artery, your first rib, your phrenic nerve, and specifically your fascia, and then your pleura. How this relates to ultrasound, so these are the structures that you'll be looking for. So you'll be identifying your ribs, your pleura, your clavicle, and then the vessels, and using, as we've previously discussed, pulse wave as well as other forms of Doppler to be able to identify which is your subclavian vein and which is your subclavian artery. It is difficult to do ultrasound-guided subclavian, particularly not everyone's anatomy is amenable to that. And so what I'd like to go through in the workshop more specifically is just becoming a bit more lateral and identifying your auxiliary vein, which takes you a little bit out of the red zone in terms of avoiding complications, and becomes a little bit more accessible, and placing a central line in that area in most people will still be able to be long enough to be an adequately placed central line. Here there's a little picture at the bottom which identifies the axillary vein, and using the rib as a landmark on your ultrasound to be able to enter the axillary vein. Another way to identify the axillary vein is to start down in the arm with your brachial vein and follow it up superiorly. This is the vein that I go for very, very regularly, and even in super morbidly obese, in multi-traumas, it's an excellent vessel with you've minimized some of the risk factors associated with your subclavian. Internal jugular, this is the one that's very commonly used, probably the most commonly used in all of the ICUs that I've worked in. So in terms of anatomy, so medial, obviously, you've got your internal and common carotids. Important to miss. Well, important not to miss, but to miss from a point from the trajectory of your actual needle. You've got skin, superior fascia, sternocleidomastoid running anterolaterally. Posteriorly, you've got obviously your transverse process of your cervical vertebra, your levator scapulae, and your other spinal muscles. And then also posteriorly, you've got your phrenic nerve, which is important in particular patients, particularly respiratory failure, and sometimes quite distally. And by distally, I mean close to the thoracic inlet would be the first part of the subclavian artery. This is a picture, obviously, of the short axis of the internal jugular, this person's right internal jugular, and very nice angle of the needle entering the vein there and showing the aspiration of that venous looking blood. What you see up in section A and B at the top there is just that compressibility that we talked about right at the beginning, where you can visualize the compressibility of your vein there. It's almost entirely obliterated in the section B there, and in terms of site selection, there is, in a hypovolemic shocked patient, this may be a very difficult vein to enter. Even if the patient's head down and fluid loaded, you might be aiming for quite a slither of a lumen of your vein, and may have to time to respiration, because obviously with respiration intrathoracic pressure changes, and hence the lumen of your IJ changes. We'll go through a few tips about how to still put in a line to those without jumping out every time the patient breathes. And then the femoral. So the femorals are also common. Everyone knows the femoral triangle, hopefully, and the little way of remembering it in terms of navy or naval from lateral to medial in terms of nerve, artery, vein, empty space, lymph nodes, or Y fronts, whichever one you like better. Here is quite a wide window of the femoral triangle, which I quite like in terms of identifying the surrounding structures. So you've got sartorius and your rectus femoris laterally and your pectineus medially, as well as your vein, artery, and with the eye of faith, your femoral nerve. I put this in here really just as a bit of a note or a word of caution, which is that some people, well, a lot of people have a really big great saphenous vein, which obviously feeds up into the femoral vein at around about the femoral triangle. Does this matter? Well, sometimes yes, sometimes no. You can place a central line into the great saphenous vein and it'll probably work all right. If you place a vas cath into the saphenous vein, you may run into trouble. Two main reasons why. Number one is it takes a more convoluted route towards the central venous compartment, and hence you may bend or find that you actually can't turn the corner of the junction between the saphenous and the femoral vein because it's a thicker and less compliant catheter. And the other thing is in terms of the length of your catheter, if it doesn't make its way all the way up into the IVC or at least into the common iliac veins, then your flow rate on your dialysis machine may be compromised. Similarly, putting an ECMO catheter in there is a contraindication because you will not get the flows the bend will be will compromise your flow too much. So just I know because it's quite often it looks nice, it's a bit more superior, but I would advocate for and with good ultrasound technique, avoiding that and going for the nice femoral. Contraindications. So I've already alluded to this. Really, there's really nothing that's a complete contraindication. But there's considerations and certainly things that you would definitely want to avoid. Or by avoid it, a central line would not work in some of these situations. So an obstructed vein, a lot of this is common sense, a stenosed vein. We've already talked about raised ICP and severe coagulopathy, as well as respiratory failure. And a contaminated site or a traumatized or a burned site we've talked about. I like the bottom one because it says uncooperative awake patient. From personal experience, they're the hardest lines that you're ever going to put in. They might look like they might be easy because the patient's, on the surface and not as sick as you're intubated on triple inotropes, but someone who's thrashing around, delirious, can be very tricky in terms of putting a line in. It's not a contraindication, but it's something to consider. Complications. I think we can probably actually I might just open it up to the floor again. Sorry, I've not involved you as much as I normally would. So any complications that you can think of, just shout them out again. Pneumothorax, yes.
Yeah. So there would be general and then site-specific ones.
Yes, very good.
In terms of site-specific, so right IJ and right subclavian, high risk of pneumothorax because of the high apex of the lung.
Yep.
Left-sided, there's the thoracic duct down lower, so
yep.
particularly with the left subclavian. And then I believe that with femorals, there's a higher risk of arterial puncture because of the anatomy.
Yep. I like the way that you've separated them out there. I've done a slightly different separation, which is your sort of complications associated with actually putting the line in, and then complications associated with having a line in terms of the moderate to longer term. But yes, however you'd like to think about it, but just having that sort of background knowledge about, okay, what is the specific and general risks associated with this particular patient and this particular line, which is a good way to approach both clinically as also for exams. So in terms of direct, so obviously bleeding, any supra or more supraclavicular, also your subclavian lines, with the insertion of the wire, there is a risk, as well as the wire, but also the catheter, of arrhythmias. In a patient who's hemodynamically compromised, this might not be tolerated very well, so it's important to keep an eye on that. Arterial puncture we've talked about, and then I would argue that arterial puncture, although something you would try to avoid, is certainly not as bad as an unidentified arterial puncture, which then becomes a dilation. Guide wire lost, hemopneumothorax, endotracheal tube cuff puncture, you'd have to be quite a long way from home. I certainly haven't seen one happen, but it does come up in the literature a fair bit. And then nerve injury and other surrounding anatomy, which Ariel has pointed out very nicely. In terms of the catheter or longer term complications, so the catheter itself in terms of fracture or tip displacement, so migration of your tip, blockage of your lumens, certainly not an uncommon thing, and with that comes the risk of infection. Fibrin sheath formation, and we've certainly all seen someone who's had their central line removed because it's thought to be a source of infection, and they have a SIRS response prior to that removal, and then in very severe cases, vascular erosions, vessel stenosis, which is important, particularly in subclavian veins, and particularly in people with end-stage renal failure who may be needing AV fistulas to be formed in the future. Tips and tricks. So I've mentioned some of these already, but these are the things that I've learned over the years that I'm hopeful that if you take away a couple of them, you might avoid some of the slow learning journey that I had. So perform your ultrasound survey we've been through, and then where you cannulate the vein can matter. And the reason, what I mean by that, if you imagine your cross-sectional view of your vein is a clock face, ideally you'd like to enter your vein at 12 o'clock or somewhere between 11 and 1 o'clock. It's not to say that you can't enter elsewhere, but you will run into trouble in terms of dilation and risk of dissecting the vessel that you're in if you're running your wire up through the side of your vessel. Vas caths, if placed at the too close to the edge of the vessel, particularly the access port, will suck in the wall and you'll have issues with flow. So just again, good ultrasound technique to be able to see that your needle's passing through the correct place of the vessel is important. Shoulder shrug for subclavian. Now, I think I skipped over this a little bit earlier. We can go through it in the workshop, but basically this is something that can be really helpful because of the anatomy of where the subclavian runs. Quite often the clavicle's in the way. It's really quite a pest. Not so much for entering the vessel, but for your placement of the footprint of your ultrasound probe. So getting someone, if they're able to, a patient to shrug their shoulders, or if some other alternative is placing a rolled up piece of towel behind the same scapula on that side, just to open up that area to really give yourself a bit more window, is helpful. Seeing the needle's not good enough, you have to make sure it's the tip, and really if there was any take home point, that would be it. Left versus right. Now, Ariel did mention this a little bit in terms of anatomical differences between left and right and the things that you'd want to avoid. Similarly, for subclavian lines and PICC lines, the trajectory might be easier on one side than the other. Quite often on the right-hand side, the subclavian takes in some people, quite a sharp turn into the superior vena cava, and you might find that the left-hand side has a more gradual angular run through the brachiocephalic and into the subclavian, into the superior vena cava. Trendelenburg, as long as there's not contraindications to head down, this can always be your friend. And then in terms of short axis, aligning your probe. Now it's important to make sure that even though short axis is you're just seeing the cross-sectional view, it's important that you know the direction of the vein so that as your needle progresses, that you're following the vein on its trajectory and not ending up out the side. And I'll talk to you a bit more about that. There's a picture in the next 1 or 2 slides that shows that a bit better. Let the guide wire guide you. I've talked about that. Obesity, just considering that. Position well, secure well, and dress well. You'll always make friends that way. I won't linger on this slide, but this is actually a CT sort of reconstructed scan of that shoulder shrug that I was talking about. Hopefully it projects well. So you can see the clavicle, and just sort of posterior to that, you've got the subclavian vein, and then tucked behind subclavian artery. But the angle to try and get to that subclavian vein is going to be quite tricky with that clavicle like that. So then you can see that by distracting the clavicle upwards by doing a shoulder shrug, you can open up the angle in which you can place that line in there. And this is showing on the picture on the right, you've got quite a hefty turn from your subclavian vein into your superior vena cava. Sorry. As opposed to the left-sided where this is gradual descent. Things that really bug you with an ultrasound and that you can save lots of time would be that it slips off the bed. Making a clear decision about where you're putting it or having a little clamp there so that doesn't happen can save you. Holding it backwards, align yourself so that you know what is left and right on your screen and left and right on your patient. Pushing it too hard, particularly in an unwell patient who really doesn't have a high central venous pressure. You'll get into the vein, you'll think it's fantastic, and then you'll let go of your ultrasound probe and pop right out because it was compressed underneath it. Needle not in plane, I'll talk about that in a second, and running out of battery. Setting up your space, as I mentioned. This is the needle not in plane. So I mentioned before, if you've got a cross-sectional view of your vessel, and being sure that when you're moving your ultrasound so that you can keep your tip in view as you progress towards the vessel, ensuring that you're doing that in the trajectory of the vein, as you can see right on the left there, as opposed to what's happening when it's malaligned on the right. And when you see it and in the middle, you think, oh yes, I'm going to enter this correctly. But as you move towards with your needle, you've actually gone off to the side because the vein's gone on a different angle. The way you can check that is if you've got a picture, which is a lovely picture here of your 2 vessels, just tip the top of your ultrasound probe backwards and forwards. And so what you're doing there is just running up the length of the vessel. If on your screen the vessels move one side to the other, then you're not well aligned because what you're seeing is a cut through at a different point of the vessel. So do that as a little check to just make sure. So then when you're actually going in there with your needle, you can follow your needle right all the way along the vessel until you finally enter right at 12 o'clock, which I know you can do. The final thing to say is just about safety and quality, and moving as you become more senior and you put more lines in, you'll become teachers yourselves, and these are the points that really make for safe healthcare delivery and for excellent delivery of education as well. In ICU specifically, is where most of my knowledge is around, there are standardised bundles of care and accreditation for central line insertion. These are advocated for by the College of Intensive Care and are helpful in terms of making sure that our trainees feel supported and that they have the supervision that they need, particularly early on into their training with central line insertions, because it's not a small procedure, and it certainly carries with it certain morbidity if done incorrectly. ANZICS, which is the professional body of intensive care for Australia and New Zealand, have a very clear documentation and guideline in terms of the standards that need to be followed for insertion and maintenance of central lines, and they also have a CLABSI, so central line associated bloodstream infection registry, where they will audit not only units but nations as well, to demonstrate that the introduction of things such as bundles of care and unit accreditation have had tangible improvements in terms of patient safety and outcomes. Just to finish off, there's a few x-rays. So the x-ray is used as a way to see where your line is once you've done, and also to identify any complications. So hopefully it won't be news to you if you see a complication on here, and certainly be something that you hopefully don't ever see. Is anyone able to tell me what's going on in this x-ray?
Looks like it's gone in the right IJ and then maybe into the aortic arch and back up one of the other major or medium-sized vessels. I'm not sure. Yeah,
it's taken a funny loop. It's gone. Yeah, it's a venous catheter. So
venous. Sorry.
Yeah, so it has gone into the IJ subclavian. It's gone back up the brachiocephalic and it's making its way out to the left subclavian.
Yeah.
This is not the worst. Ideally, you could pull this back and you might get quite a well-situated central line. So this is not too bad. What about this one? Draw your attention over to the right shoulder.
So it's gone down the right IJ and then it's kind of come back up the subclavian.
Isn't it? So it's actually subclavian lines that's gone north. Again, tricky to avoid. You might be able to, similarly to PICC line insertions, there's a few little tips and tricks. If you're sterile, if you've got a helpful colleague nearby, that if you have a sense that you might have gone the wrong direction, someone can do a little ultrasound of the IJ to check that it's not gone up. Yes?
I have a question. So for that shoulder shrug that you mentioned, is that useful for the PICC line as well?
It's useful for the PICC line if you're going to the right side, because it can pull the subclavian vein up and reduce the angle between the subclavian vein and the SVC. The PICC lines are tricky because it's difficult to navigate them. I would advocate for doing anything that you can to try and get the PICC line to go the right direction. I do shoulder shrugs, but I do that in context of actually having the patient's arm quite abducted and externally rotated, so that I'm reducing that angle already and kind of already doing a shoulder shrug by having their arm out like they're stopping traffic on a nice, well-supported bench, so that you have a nice minimised angular journey from the site of insertion through to the SVC. This one, this is hopefully what you'll never see. it's not projecting well here.
It's a pneumothorax.
Yeah, so yep, it's not only just a pneumothorax, it's a tension pneumothorax. There's quite significant mediastinal shift to the left. There's a right IJ line and there's a left IJ line. Was it caused by either of those? Your guess is as good as mine, but it's certainly a known complication. And this is one of those things that you try not to get an x-ray of, because clinically this person is likely to be quite unstable and clinically would need decompression. But that's an interesting image. And then this one, it doesn't project well, so I'll just walk through it with you. There's a lot going on in this x-ray. Obviously the patient's intubated with a thoracic and almost inferior cervical fixation device. They've got a right IJ line, and they've also got a left subclavian line that if you follow the trajectory, you can actually see it projecting over the aortic arch and into the descending aorta. So the differentials for this is that unfortunately this has gone into the subclavian artery and then into the aorta. However, the differentials would be if the person had a left-sided SVC or a persistent left-sided internal mammary vein that just somehow managed to cannulate. However, on this particular patient, we know from previous imaging that unfortunately they didn't have any of those things, and that this was an arterial line.
What do you do if you do an arterial puncture and then you dilate it and then you're like, oh no, it's an artery?
Yeah, that's a good question. So for those of you online that couldn't quite hear that, so the question was, what do you do if you do an unrecognized arterial puncture and then a dilation? So the guidelines from the literature on that is that you place the catheter in. So it's a significant hole in the artery, so you place your catheter in to sort of stem the hemorrhage. You identify that line as being arterial and make sure that nobody uses it. And then you consult either interventional radiology or vascular surgery, because that patient needs an operation to be able to repair the defect in the artery. Unfortunately, they will also need a workup for complications from that. So the risk is, of course, hematoma and bleeding around that site, but any air embolism or any thrombotic complications of that. So the least would be a brain CT, but also potentially a full body scan to identify if there's been any emboli from that. In terms of due diligence, obviously this would be a SAC1 reportable adverse event, and you would need an open disclosure process, which can happen in due time. But it's a known complication, and following on from what I said quite early on in the talk, which was the consent process, it is something that is, as I said, a known complication, and we do consent for the unfortunate episode that might happen. But that's what you do. Any other questions?
How far are you meant to put the central lines in?
Yep, so the question was how far are you supposed to put the central line in? So it depends on the person in the terms of the size of the person, and it depends on the indication. So most adults with a femoral central line, you would insert to the heel. The one thing you have to think about with the femoral is that if it's a small person, that you don't want the tip of the catheter to be abutting the renal veins, but that would be uncommon in a normal sized adult. In terms of the subclavian and IJ, usually it's good practice, particularly when you're starting, to just get an idea, even with a tape measure, a rough estimate about where you ideally want your catheter to be. So the tip is usually ideal in the distal part of the superior vena cava. So identifying where that is on the patient's chest, and then doing a rough measure to where you think that your central line is going to be inserted into the skin, which you've done on your scalp ultrasound earlier on, and just placing that. There's a rough rule of thumb that in a normal sized Caucasian adult, that most people will sit for the IJ between 15 and 20 centimeters. For the subclavian or the axillary, obviously the axillary you need to enter deeper, so place it deeper because you're coming from more laterally. Somewhere also between sort of 15 to 18 centimeters, depending on where you are on the chest. I would recommend measuring it for the first few that you do. Is there a problem placing it too deep? Well, identification of that with the X-ray and pulling it back. Atrial arrhythmias can be hemodynamically compromising for a patient who's reliant on the atrial kick. Obviously, if you place it too deep, it goes into the ventricles, there's a risk of ventricular arrhythmias, which obviously we want to avoid. Pulling it back, though, is easier than putting it in too shallow because you can't advance it, because you've already, that once your procedure is complete, you no longer have your sterile field. So if it's too shallow, unfortunately, the patient needs another procedure. Yes, Andres.
So you mentioned the femoral approach. So what's your advice on how to choose between, or how to find the femoral vein as opposed to the saphenous vein?
Right. So yes. So the saphenous vein actually enters the femoral vein at lots of different places depending on the person. So it's not a reliable landmark. So my technique is to take time and do when you're doing your scalp ultrasound beforehand. For a patient, and it comes down to positioning the patient and taking that time early to set up your area, optimizing your ability. So if someone is obese, then asking a wardie or someone helpful to hold up the apron so that you can access the femoral triangle easily. Using time to start identify your landmarks, place your ultrasound where you think the femoral triangle is likely to be based on your landmark technique, and then follow your vein distally and superiorly. And what you'll be able to see, hopefully, is that you'll be able to identify the saphenous vein and the femoral vein in your same frame on your ultrasound screen and be able to see the insertion point. I would recommend using Doppler in a similar way to what I've described in this talk to be able to identify. Sometimes if you've got your saphenous vein and your femoral vein in the same screen and also some tributaries of the femoral artery, it can be quite busy on your screen. So identify your anatomy and venous versus arterial using that and just follow it up until you can see where it inserts. Sometimes it will insert quite high, and that's not a problem. It just means that you know you can even enter the femoral vein below where the saphenous vein joins, but just knowing which is the vessel to go for, and the only way to do that is to be able to see where it enters, and then you just use your ultrasound technique to guide your needle into the femoral vein.
Thank you.
So the last is just the references, and yes, there is a veterinary, the veterinary reference there. I think it was one of the images of the vessels with a line in it was the best. So please, Andras has my contact details. I unfortunately won't be able to speak on this year's course, but if there's any questions, he'll be able to pass on my details. Happy to receive them. Thank you.